yes, I'm going to be talking a little bit about some of the work that Krista Vandenborne has been leading over the last several years of using magnetic resonance in imaging. We'll talk a little bit about the work that we've done in Duchenne and where that's going, and as well as how others have done some similar work and how that can tie in, very importantly, to individuals with FSHD. And so when we think about clinical trials, really trying to be able to move forward, like Mark Stone said early on, of getting to that ultimate cure, there's various steps that need to go on for science to proceed. First, when there is a promising potential therapy, these start off with a preclinical kind of study that involves cells and animals. Once these are, we have these results that can move ahead, they go to more of a phase 1 kind of study. This study involves healthy volunteers, individuals without the disease process itself, where the purpose is looking at developing the proper kinds of dose. So there's various dose ranges that are done, looking at the safety from a short-term perspective, and looking at the pharmacokinetics, really looking at the absorption, distribution, metabolism, and excretion of this kind of therapy, drug, medication that's ongoing. With those results, as they are being able to be moved ahead, it goes to a phase 2 trial. Now, this trial does involve patients. So now we're looking at verifying that the right dosage is being utilized that is not only safe, but can also be what we are hoping will be able to have some efficacy. But we're really focused on pharmacokinetics still of what's ongoing, so that this can then move to that next phase 3 trial that, again, does involve patients, but this is a much larger group of patients now that are recruited and are enrolled to be able to have this dosage that is distributed, but there's randomization so that we can see that some individuals are getting the therapy, others are getting everything except for the actual therapy itself, to be able to determine the efficacy of the intervention. And so with this whole process, one of the elements that's key to keep in mind is that we need to have measures that are very sensitive in order to detect if there is actually a therapeutic benefit of what is ongoing. And that will help to expedite not only the drug design and delivery, but ultimately to get it into the hands of patients and families to be used for further care. And so with this intent in mind, Krista Vandenborne and her team have been great of really focusing on muscular dystrophies for a couple of decades. But in particularly, over the last decade, there has been a multi-site study that is focused on boys with Duchenne muscular dystrophy. So this is a natural history study, which was explained previously and by other speakers, that is really looking at trying to assess what is ongoing from the disease process using MR. And there's various techniques. This is in the bottom where we have images of T1, T2, Dixon, and spectroscopic measures that I'm just going to touch on as we move ahead to give you a flavor of what is done. And so as we've worked on this study for these boys with Duchenne muscular dystrophy, it has progressed to where we're continuing to work with the boys with Duchenne, but also now other individuals with other forms of muscular dystrophy, individuals with Becker's muscular dystrophy, limb-girdle muscular dystrophy, myotonic dystrophy, and now with UF being a site, a part of the FSHD consortium, we're looking forward to being able to work further and take what we have done and apply it further and get more development of what can be done for the FSH population as well. And so it used to be, I've been involved in this work for the last 14 years, and a dozen plus years ago, when we would have families who would come, I would be talking to them as far as participating. I'd say, it's our intent and hope that what you and your family members are participating today will ultimately be part of clinical trials in the future. And now I look at families and say, what you're participating in today has been and will continue to be utilized in clinical trials as we're refining and developing even better and more sensitive tools for future clinical trials. And so you can see here in this list, these are some of the clinical trials that have been implementing these types of MR methodology that we've been able to do and study thus far. And it's important to note at the bottom that there's now this international consortium that involves both academics, governments, and industry that have partnered to work to register MR biomarkers as a predictive tool for clinical trials. So this has really gained a lot of momentum and has been a big push as far as getting this development of clinical trials moved along and expedited. And well, we really think about what is it that we're measuring. And so this schematic demonstrates a little bit about disease progression. And so in neuromuscular disease, usually what we'll find is in the muscle cells themselves, the muscle cell membrane, known as the sarcolemma, can become fragile, it can become damaged, and that can then, as we go along with the disease progression, can lead to inflammation and swelling or edema. Later on, those changes continue and it leads to apoptosis or cell death and atrophy or a smaller size of the muscle itself. And ultimately, it can lead to where those contractile elements that generate force within the muscle are replaced with fibrous tissue and fat infiltration. And therefore, the muscles can't generate the force needed for movement and what is done. So we're trying to be able to target what can we do to measure these kinds of disease changes that occur. And so what we do is we have this great device that we have actually 2 of them that we utilize that are solely dedicated for research at the University of Florida. These are 3 Tesla whole body MR scanners. Whereas you can see here with this little boy, we have various padding, blankets, comforts, just to make sure people are comfortable. We have a video screen where people can watch movies or they can listen to music, so that these kinds of scans are done without any sedation and no injectable contrast agents like gadolinium or anything. So this really is a non-invasive means of getting this information. And this is a representative picture of the thigh muscle. So this on the left, this is a control. This is a healthy individual without any disease, where if we're looking at the thigh, the white portion here is the subcutaneous fat of the thigh. And this dark gray area throughout that looks relatively similar, homogeneous, is the muscle tissue of the front of the thigh, the quadriceps, the hamstrings, and then this is the femur, the long bone of the thigh itself. And when you look at how consistent this looks as far as healthy muscle compared to an individual the same age who has Duchenne muscular dystrophy, we now see this white fat of the subcutaneous portion. Now this fatty infiltration has started to enter a lot of these muscles, again, replacing that contractile tissue so that those muscles can no longer generate the force that is needed. And this kind of methodology really is done in a non-invasive means. It minimizes burdens on participants. It's very sensitive in that it can be utilized so that it can be able to detect changes in a quicker rate relative to a lot of other tests, and which in turn means that there are fewer individuals that have to be recruited into different kinds of trials. And this is very robust, high quality, and a trustworthy means of assessment. And so when we think of the fat fraction or the fatty infiltration as part of the disease process itself, I mentioned there's spectroscopy and imaging. And so here on the left, this is this MRS, magnetic resonance spectroscopy, where what is done is there's a digital box or voxel that's placed within a muscle within a specific region. And within that area, we're able to get specific chemical information. So we're able to get specific information that comes out in peaks so that we can quantify or measure how much water there is, how much fat there is, and other metabolites. An alternative is, instead of utilizing this where we're looking at just a specific area of muscle spectroscopy, is utilizing imaging. So there's this chemical shift encoding imaging, often is called Dixon imaging, where we're able to get some representations throughout here is the thigh, but throughout a region of the body. So we're looking at a much larger area. So it's a higher spatial resolution, where we're then able to also put together and see fat that is now invaginated within muscle. And from both of these techniques, we can now get a variable or a measure of what we call fat fraction, which you can think of as like the percentage of fat in the muscle, which comes from the fat divided by the sum of the water and the fat itself. So this gets us at that measure of that fatty infiltration as along that disease progression line. In this slide, we now have it enhanced where we can see a little bit easier some of these changes. And so here the lipid or the fat is what we see in green, and anything that is water, or you can think of as healthy muscle, is in red. And so this is for, again, a boy with Duchenne muscular dystrophy. And we can see as we go across from about 7.5 years of age, when we get closer to 10 years of age, we see a little bit of the green that's in this lateral gastrocnemius muscle of the calf. And as we go along this point, we start seeing a little bit now involved in the medial gastric of the calf and some of the other muscles of the anterior front of the lower leg. But once we look more and more as the disease process continues with age, we see that ultimately the grand majority of the lower leg here is completely or almost completely infiltrated with fat, leaving these muscles relatively unable to generate force. Rebecca Wilcox, a member of our team, headed a paper that looked at the longitudinal changes that were going on in this type of work. And so here in this figure, this VL, that's the vastus lateralis, that's just a muscle of the thigh. So this is the fat fraction of one muscle of the thigh, and looking at it on this y-axis. And across here, we looked at 4 different age groups of boys with Duchenne, those 5 to 6 years of age, 7 to 8, 9 to 10, and 11 to 12. And the green bars, these are healthy controls without any disease. The royal blue bars, these were the boys with DMD at their initial testing at baseline. And the darker blue were these same boys where they were assessed for the fat fraction of the thigh 12 months later. And we could see in this figure that the fat fraction, the vastus lateralis, or the thigh muscle, was greater in the DMD boys than the control participants at all ages, and was higher at 12 months relative to their baseline initial testing. This increase was significant at all age groups. And in this same study, what Rebecca did is she then said, well, let's go ahead and look a little bit at these same boys relative to some of the common clinical measures. And so one of these common clinical measures is the 6-minute walk test, which is not only used in Duchenne, but is also used in those with FSHD and other forms of neuromuscular disease. And she divided the boys into 4 different groups or quartiles. The first group, these are boys that over a year, these individuals actually had a slight increase in the amount that they walked for their 6-minute walk distance, so they could walk a little farther. The second quartile, these are boys that really didn't have any change in how far they walked over a year. And then these other 2 groups are boys who actually had a decrease in the amount that they could walk in 6 minutes. So they had a decrease in their clinical abilities. And what we have in these figures is on the y-axis and these black bars, this is a change in what is noted as inflammation. We have used what is known as T2 imaging. And on this other portion of the y-axis for the gray bars is the fat fraction. And so for the boys who actually had a slight improvement in their walking for the 6-minute walk test, they still were demonstrating increases in inflammation and in fat fraction, as did also the boys who had a stable, they didn't change in their 6-minute walk distance, but they did have changes that were noted for disease progression in the thigh based upon inflammation and fatty changes that we could quantify and measure in the leg. So this gives really strong evidence that these MR biomarkers are responsive to disease progression and able to detect even subclinical disease progression in DMD before we can start to see it with some of these other clinical tests of walking and function. We've also recently started to look at some boys that have been undergoing gene therapy types of treatment. And so this is a picture, an image of the thigh. This is a transaxle image of the thigh, where we see here, this is the femur, the long bone, and this is the quadriceps or front of the thigh and the back. Here, the black is actually the fat. And we can see that we have little bits of black kind of interspersed within these muscles for a boy with DMD who has not received gene therapy, relative to a boy who has received gene therapy over 18 months. And when we looked at some of these boys regarding what had changed over this time period, again, we have on this y-axis this fat fraction, how much fat is within the muscles. And we saw down here for the controls without muscular dystrophy that this stayed very low and didn't have any big changes. For the boys in the natural history that did not undergo any gene therapy, we saw that they had an increase in what it was ongoing for their fat fraction in the thigh. But the boys of the gene therapy had relatively no change at all that was occurring over that time period. And although no statistics were performed, the group mean data reflect a lower fat fraction in these gene therapy treated group of boys relative to what we see the boys who are not treated. And so again, this shows a clinically meaningful increase in fat fraction for those who are untreated and an ability to halt that with this small sample that we had here. Now, others have been applying these kinds of techniques to patients with FSHD. Here, Mull and colleagues examined the fat fraction in 140 patients with FSHD, and they looked at individuals across the clinical spectrum with varying kinds of abilities. And then they evaluated how these MR measures related to or correlated with clinical function measures. They found the most affected muscles in the leg were the hamstrings, back in the back part of the thigh, the adductors of the inner thigh, and then some of the quadricep muscles like the rectus femoris, as well as the medial gastrocnemius of the lower leg. These same muscles were not only the ones that were most affected, but they were the ones affected earliest, and even in patients that did not yet demonstrate any leg muscle weakness. Our colleagues in Denmark took an approach of performing whole body imaging and examined muscle fat fraction in 45 patients with FSHD at different portions of the body here close to the neck or the cervical area, the mid-back thoracic area, the thigh, and the lower leg. And they found fat fraction and changes in fat fraction were largest at the level of the thigh as well as at the thoracic or the mid-back area. And in using this whole body imaging approach, this same group also found similar results relative to Mull, who I mentioned earlier had found for individual muscles. So this has the fat fraction, and we can see what is going on from a change over time for these different kinds of muscles that are throughout what they looked at these varying portions of the body. And they found that the medial gastrocnemius of the calf and the hamstrings of the posterior thigh, followed by the mid-back areas of the thoracic paraspinals, this is where they had the most infiltration of muscle fat. And of course, in order for the MRI to be useful in clinical trials, it's critical that the MRI measures correlate or have a relationship with clinical outcome measures so that they're meaningful to patients. Our group and others have studied both the correlation between fat fraction and clinical outcome measures by implementing functional measures such as the 6-minute walk test, stair climbing, 10-minute walk run, and other tests during study visits. And Mull here published some very nice work in this area to show strong correlations between on the y-axis of what was going on for fat fraction relative to motor function measures, the 6-minute walk test, FSHD clinical scores, and the Ritchie scores, which look at clinical meaningfulness and strength. And so we see that these MR measures for muscle fat fraction have a very strong relationship with what is going on from a functional ability standpoint as well. So I talked a lot about down at this here is looking at this fatty fraction, but there's also an important target in MR biomarker development, and that's the able to assess this muscle inflammation. This isn't only true for Duchenne muscular dystrophy, but is certainly true for FSHD. And a common way of evaluating inflammation or edema, swelling, is what is known as stir imaging. And so here in FSHD, these areas that are hyperintense or light up or very bright here that we can see on the stir images, these suggest that there's a pathological stage that is likely occurring before any fat infiltration. Because if we look at these patients, so this is the same patient here above with an image that's only showing fat. And we can see here that this muscle looks relatively healthy, but when we look at it on the stir image, it shows that while there's no fatty infiltration, there's a lot of inflammation that is ongoing. We see similar kinds of work here with this kind of patient where we don't see any kinds of fatty infiltration, and yet there's a lot of inflammation that's ongoing. And this group did muscle biopsies of these hyperintense regions and have revealed active inflammatory cell inflammation that we can see with what is ongoing in these other kinds of slides based on histology. Several groups have suggested that many patients with FSHD may experience long periods of stability interspersed with acute onset of inflammation and rapid progression of fat infiltration. If that is indeed the case, then stir hyperintense muscles might be ones to direct therapy to for obtaining improvement. Further evidence of the value of stir imaging in FSHD has been provided by Dr. Tapscott's group. In this paper, they used needle biopsies to examine histopathology as well as expression of DUX4 target genes believed to play a critical role in FSHD. In this slide, similar to the previous, you can see in this area where there's this hyperintensity by stir imaging that, again, does not have any fat infiltration, this other kind of imaging that's done, that we look across, and from the histology that's done, these biopsies, these muscle biopsies from these areas that were done in that stir positive areas showed high levels of DUX4 target expression compared to the muscles that had a normal appearance. These results and others have provided evidence that stir images have substantial predictive value in identifying muscles in the early phase of muscle damage with active disease as determined by histopathology and DUX4 target gene expression. These kinds of methods might be useful in early phase clinical trials to demonstrate target engagement in therapies aiming to suppress DUX4 expression. So in a sum, we've looked at, and others have looked at, MR measures and fat fraction. They're sensitive to disease progression, what we've demonstrated in DMD, what others have started to look at with FSHD. They relate to have clinical tests for function, and they predict loss of function. MR measures of fat fraction are currently used in several clinical trials for muscular dystrophies as endpoints or outcomes, and should allow for these trials to be shorter in duration and only require fewer participants. And for these STIR measures, these have the substantial predictive value for identifying muscles with DUX4 target expression in active disease in FSHD, which again have that potential for providing an early therapeutic readout. The importance is being able to say, how can we now best leverage this knowledge that we gained in Duchenne and other muscular dystrophies to advance the therapeutic development in FSHD? And so a recent paper published, here are different clinical trials that have been done and are ongoing in FSHD. And we can see that the majority of those that are still ongoing are using MRI, as evidenced by these red asterisks, as an outcome measure, with the goal of getting through these phases and getting things moved forward to therapeutic development. And it's been stated specifically for FSHD that MRI has the potential to be a powerful clinical outcome measure and can be performed in most patients irrespective of disease severity. So this is a team effort with many individuals here at the University of Florida, Krista, Vandenborne, Glenn Walter, and many others, as well as collaborators in Oregon, Pennsylvania, and others who provide great clinical and statistical insights. These are various funding sources that have been very generous to support this work, but really it's so key to recognize the participants and their supportive families, both those who have assisted in the past for what has been ongoing, as well as we look forward to working with you with FSHD so that we can move forward to enhance both drug and therapy design and trials. And just like Mark Stone said at the beginning, ultimately find the goal of a therapy that would cure this disease. So thank you very much.